Hello. Hello, everybody. So, you had your good lunch, I hope. I hope everybody's full now. So, to start off the first session right after lunch, we'll have a debate. So, it's more exciting and you can decide whether you're the pro or the con. I'll introduce the chairperson for the debate, our Dr. Sharidan. You have seen him perform. Just now you saw him in fully gowned with mask and all. So Dr. Sharidan, who's the scientific committee chairman, who will chair this pro-con debate. Thank you.
Thank you, Madam Chairperson. I think if you look at the schedule, it was supposed to be Associate Professor Shanas, but apparently there's nobody else to cover his ICU in UMMC, so I'm sitting for him. Okay, so hopefully I know our vagal tone is a bit high now, but since it's a debate, then hopefully you guys will be entertained by our esteemed debaters here. The title of the debate is Fascia Iliaca Compartment Block is the block of choice for hip surgery. For proposing the topic will be Dr. Mafeitzeral Mamat. Dr. Mafis is so basically is one of the leading members of the Special Interest Group of Regional Anesthesia. Currently would be soon my colleague in Gleneagles Medini, previously of KPG Rawang and UITM. Okay. He has done a fellowship in Royal Perth Hospital, and opposing the topic will be Dr. Victor Chee. Dr. Victor Chee is, I think, the earliest Southeast Asian who has done the proper regional anesthesia fellowship, and he hails from Singapore. I think these two debaters will enlighten us on the topic and entertain us. So without further ado, I would like to invite. So the format will be about 10 minutes each, and then about 5 minutes or so each in rebuttal. So each debater will have two appearance. Okay, without further ado, I invite Dr. Mafeitzeral Mamat to propose the topic. Fascia Iliaca Compartment Block is the block of choice for hip surgery. Please.
Okay, time starts now. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi ta'ala wabarakatuh. And a very good afternoon. I know we are just after lunch, and I do hope that whatever the topic that we are presenting and talking about today would go deep into your minds. And don't worry, this is not a multi-level marketing debate or presentation. All right. Fascia Iliaca Compartment Block is the block of choice for hip surgery. So I will be giving that definition in terms of that topic initially that we've been given, the angle of justification, my arguments, and of course a bit of the closing. All right, this is the particular hip joint that we're talking about. As you can see, a complex arrangement made by God, and the function that can make us function well, walking around like I'm doing now. Again, hip joint, what are the nerve supply? We're talking about the femoral nerve, anterior division obturator nerve, the nerve to rectus femoris, nerve to corax femoris, sciatic nerve, superior gluteal nerve. So with the complex structure comes the complex innervation. Again, we make it simple. We know that hip innervation, the anterior part, and from the femoral nerve, the obturator nerve, and the sciatic nerve. Okay. So hip surgery, I think, as mentioned before, the hip joint. And from the hip joint, we know that any kind of injury that we need to do an operation on, or the particular injury, we can talk about the fracture neck of femur or hip arthroplasty. All right. So again, as you know, from the topic that we've been given, it's not that I'm talking that Fascia Iliaca block is the block, the only block or the only method that you use for hip surgery. What I'm saying is how we can see in, say, the nice hip fracture management in terms of anesthesia. Of course, one of the recommendations is offer choice of either regional or general anesthesia and consider intraoperative nerve block for all patients undergoing surgery. That is my angle. Again, the Cochrane Library, which I think last published in 2010, where looking at for the hip nerve blocks for the hip fractures, all the subcostal, lateral cutaneous, femoral, triple, and psoas. Again, there's no substantial saying one better than another, but it is considered that all these blocks that you give would give significant pain relief to the patients. Again, I mentioned that fascia iliaca compartment block is the block of choice. Again, as we know that since Dallens described the particular fascia iliaca block in 1989, it has received a lot of attention from a number of anesthetists and regionalists in terms of providing an alternative to the femoral block or the 3-in-1 block. My points would be, 1, fascia iliaca compartment block, simple. Analgesia endpoint achieved for the surgical program peri-operatively. And we're talking about the whole program, that means before, inter, and post. Complications less and economical. And when we talk about the providing analgesia, what about simplicity? Simplicity is because of its basic anatomical knowledge. You know the anatomy, right? Then you would know that where exactly in terms of the description. And of course, the easy learning curve, this has been proven as well on teaching of how to do one. I guess this is one of those blocks where I do encourage my trainees before that at least the one block that you can do or do after going for this is fascia iliaca block. Because this is safe. And of course, we are talking about the landmark and technology. All right, let's go just through about the anatomy. As you know that when we look into the anatomy, there will be the fascia lata and fascia iliaca. So description for for description for the landmark technique would be the distance between, and you would try to give your local injection somewhere around this, basically after the second pop, which is the fascia iliaca, and the distribution of the local anesthetic that should cover at least the both femoral block and the lateral femorocutaneous block nerve, and to a certain extent obturator, but that can be something that we could further discuss about. Yes, simplicity, as you can see in our brochures, and why we do this here and what our motto. Now every anesthesiologist can block, just like now everybody can fly in Asia. So bringing that back, everybody can block with the fascia iliaca, so why not? This would be just the description of particular studies which show how the administration of the local and the fascia iliacal block is easy in terms of by the junior doctors or even the healthcare carers. Again, fascia, telling again, fascia iliacal compartment block is the block of choice for hip surgery. All right, next, when we talk about superior analgesia component, we're talking about the perioperative analgesia it provides. As we know that recently, our counterparts in the emergency physicians are very interested in this block in terms of giving that adequate pain relief and provide good management of pain program if they come in with fractures or injuries that require surgery. And as well, we are talking about the opioid sparing properties in terms of the population, the elderly population that we happen to get these hip fractures. So we're reducing things like delirium, etc. For this. Okay. Now, another Cochrane library database systemic review, which actually and this is one literature which actually put and see the fascia iliaca block and telling us in terms of safety, because this is in children, all are based in terms of in the systemic review, the fascia iliaca block. However, of course, the evidence is not superly strong in terms of saying, yes, we 100% recommend it, but yeah, that would be something for you to know in terms of what we have, and hopefully with further, further research done, that we would be more confident on that point. All right, low complication rate. Here, I guess in terms of anatomy, when we talk about the position or L of the local anesthetic deposited, and also the low concentration, because we're talking about volume. I think there will be some argument on the volume and in terms of safety, but when you consider where you actually deposit, okay, now it says in the ultrasound technique, you know your fascia lata and then your fascia iliaca, so you want to give in this particular plane, as we all know, fascia iliaca is a plane block. We do not really aim directly, but we are hoping, not to say hoping, we know that the spread in the plane, the local anesthetic would cover the nerves that means what we aim for. Example, if we do a femoral block, either is in ultrasound, or before in terms of the landmark technique, we know that the position of the femoral nerve can be variable. And this is where, when we talk about safety, we are worried about neural injury, that which can occur whether under ultrasound or not under ultrasound, to the femoral nerve compared to the fascia iliaca. You know, the deposit is definitely a distance away, even at the moment of normal anatomy, unless it's not normal anatomy. All right. And as I think here, why I'm putting this, but again, please take this with a pinch of salt, because I'm not saying that you can have neurological complication, because we know that the neurological complication is very, very small number, percentage of possibility. But what has been described, that the estimated of rate of occurrence like femoral nerve block is 0.3%. All right, so that can cause that. Coming soon. All right. Okay, cheap, definitely. All right, you don't need ultrasound. You can still do your fascia iliaca block. It can work. Okay, that's why in terms of teaching and getting the juniors to do, you're happy and confident, and you know that the patient will achieve the anesthesia that they want. And maybe something on disaster anesthesia is quite interesting, that they are actually doing this. It's in the study protocol for disaster, you know, in the low resource areas or in the disaster, where what you want to do if you have something that easy and worked. And this study will actually compare between morphine, fascia iliaca block landmark technique, and ultrasound guided femoral nerve block. Fascia iliaca compartment block, again, this is simple. Oops, it's simple. The analgesia endpoint, the few complications, and economical. Safe. Thank you very much.
Thank you, Dr. Mafis. So those were the points for fascia iliaca block in hip surgery. We will have a differing view on the opposite view, which will be elaborated on by Dr. Victor Chee. Whenever you're ready, Dr. Chee.
I feel obliged to do the MLM thing. But we'll see how it goes. Thank you for inviting me back to Malaysia. It's always a pleasure to come back to meet people who are close to my home. And to a large extent, I think we think alike in many ways. Just a show of hands. Okay, the question of the day is fascia iliaca compartment block is the block of choice for hip surgery. How many of you already believe that this is correct? How many of you? Come on. Everyone must raise a hand at one point in time, okay? So if you lower your hand, that means you don't believe it. Okay? If you believe it, so maybe about 40% of you all believe it. Okay? Now my job now is to convince you that this is rubbish. Okay? Now, the fascia iliaca block is well established in pre-operative management of hip fracture patients. Okay, that's what the literature says. That's what the practice guideline says. First responders are using it. The ER is using it. In the general ward, they're using it for pain management. But remember, we're talking about hip operations today, and this is talking about pre-operative management of hip fracture patients. Okay, I have no quip about this statement. Okay, but for hip operations, if you want to tell me and convince me that fascia iliaca compartment block is a way to go, then the science actually doesn't really tally. I'll show you why. Okay, yes, in the literature, like I mentioned earlier, in anesthesia, in North America, in Europe, right, in trauma journals, right, everyone says that yes, we should use fascia iliaca blocks for hip fracture patients pre-operatively. The fascia iliaca block is a really single short block with no needle redirection, and really what it is what regional anesthesia has become today. There are blocks that are looking for indications. Okay, we really don't know what to do with this block, but let's just see what we can find to poke, with. And we are very romantic about putting a single injection somewhere to be able to do everything. Okay, so I think he was trying to sell to you that if you put a single injection under the fascia iliaca, you can do good for all your hip operation patients. Well, I don't think so. Okay, There are three things I want you to think about, okay, over the next 10 minutes or so. That hip operations is not one animal. There are actually a whole bunch of animals there. Okay. The second thing is that the unpredictability of the fascia iliaca block is actually quite clearly laid out in the literature. When we say fascia iliaca block, we mean an anterior approach to the lumbar plexus block. That means complete successful blockade of three nerves: the lateral cutaneous nerve, the femoral nerve, and the obturator nerve. Okay, so I'm going to show you that this doesn't happen. The third thing is that what then is the best option for hip operations? Okay. Is there really one option? So we look and do this first. It's a basket of fruits. Okay, the hip operation is not one fruit; it's a basket of fruits. If you want to find a silver bullet, good luck to you. There may be 3 silver bullets, but I don't think there's one silver bullet. Okay, the hip fractures per se, there are many types. You all understand? If you work long enough, actually all of us are very good orthopedic surgeons. Okay, honestly, I can tell the junior what to do. If you miss something, I can tell you what you missed. Okay, and as far as hip fractures are concerned, there are intracapsular, extracapsular, intertrochanteric, subtrochanteric. There are many combinations to this, and because there are many combinations, there are many solutions. Okay, so if you are trying to convince me that your one block can solve all these problems that are created by our surgeons, I find it very hard to believe. And just a bit of anatomy. Okay, we all know that the hip joint is supplied by 3 nerves, right? There are branches from the femoral nerve, there are branches from the obturator nerve, there are branches from the sciatic nerve. Okay, that's a true fact. But this is the joint only. Don't forget that when you're doing surgery, you're doing soft trauma tissue that you intentionally create, right? And is there anything that can completely do this? Block everything? Well, I think there is. Okay, and it's in the central neurexis. It's not in the peripheral nerve. Okay. So, but a lot of us forget that actually on top of the joint, we also need to look after the soft tissue during the surgery. And if you remember the mapping of the skin and the soft tissue around the area, sorry, we move back one, right? The lateral cutaneous, everyone knows, right? Oh yeah, the lateral cutaneous nerve is there, So even if you approach the hip from the anterior aspect, you can still cover it. But look, down here, if you make a posterior lateral approach, you're actually encroaching on the lateral thoracic nerve, the branches of the ilio-hypogastric, as well as the superior cluneal nerves. These are the posterior divisions of L1 to L3. Many people don't really understand that, the buttock is supplied by L1. Okay. So the gluteal nerves, the cluneal nerves actually also penetrate the gluteus maximus and come superficially. So you can imagine in a posterior lateral approach, you actually split the muscle. It's going to be painful. Okay. Now, in the post-operative management of hip fracture patients, there is also clear indication from FOSS that different operations cause different amounts of pain. Okay. Here we have pain at rest, pain on flexion, pain on walking, and then the cumulative pain. Okay. On the bottom, sorry, it's all very small. These are screws and pin fixation. This is either by hemiarthroplasty or total arthroplasty. This is by DHS or intramedullary nail. Okay. So on the X-rays that I showed you earlier, there are many combinations of the solution to this fracture problem. And you can actually, it's quite. I mean, if in your practice you haven't come across it, total hip replacement is actually not very painful. Okay, so there is data, and this is correct, that actually if you do a complete hemiarthroplasty, it's actually not as painful as having a DHS, IM nail done, or even just screws put in for fracture neck or femur fixation. So ironically, if you take out the whole joint, it's less painful than leaving bits of it in. Okay. Now, also on this angle, the cumulative pain for hip operations is actually much less for knee operations, and this is true in clinical practice as well. So if we look at this data, right, from Frederick Seiber, who is a geriatric anesthesiologist who believes that we must reduce narcotic use for all patients, which is correct, right? For hip operations, right, we're talking about, okay, if you convert op day 0.1 milligram per kilo, it's about 7 milligrams. Oh, per kilo. Did I get it right? 0.1, 0.7. Is the maths right?
Yes, yes.
The maths is right? This is just stage anxiety, right? The maths is right. Yeah. So, here we're looking at first post-op day, 16 milligrams of morphine. What does that equate to? Morphine running at 1 milligram or less an hour. Is that a lot of morphine? How many agree that that's a lot of morphine? 0.8 milligram per hour. Not a lot, right? Okay. This is compared to knee replacement, where on the op day, you expect to give the patient about 48 to 50 milligrams of morphine. On the first post-op day, they require about 24 milligrams of morphine. Okay. So, in terms of total hip arthroplasty, also here I always look at the other data except the conclusions. So we draw from this study again that again the morphine consumption here up to 12 hours is only 11 milligrams, right? And for 24 hours it's only 15, and at 2 days it's only 17 milligrams. That's not a lot of morphine for hip replacement. And again, in the recent publication by the Nisauer group, right? Again, this is for fascia iliaca block, right? Don't look at the fascia iliaca block data first. Just look at the morphine consumption. 50 milligrams. In North America, the people feel a lot of pain. Okay, 50 milligrams for 24 hours compared to what Frederick Seiber's data showed earlier. So, I hope I've been able to prove to you that this animal is actually not one single animal. There are many breeds. And because of that, if you think that one thing can solve all the problems, it cannot. Now, next we go on to the unpredictably of the fascia iliaca block. Originally described by Dalens, right, it was supposed to be the solution to a lumbar plexus block, which was very difficult in those days. Right? So the solution was that we just tuck it under the fascia iliaca, we give enough volume, it'll spread everywhere, and then it'll block all the three nerves. And then we approach it from that way. It's like saying, we give the axillary block, right? If you give enough volume and push it hard enough, you'll get bilateral epidurals. Which is true, which is correct if you put it intraneurally subepidural. If you push it like this, you will get bilateral epidurals. But we're not trying to do that, okay? So in his original paper, he showed, wow, massive spread, very nice, and the spread compared to the 3-in-1 block, right? This 3-in-1 block, only like this. But wow, with the fascia iliaca block, can spread everywhere. But remember, these are pediatric patients where the bone plates are still there. They're small people, right? They can spread very, very widely. So in comparison, like I mentioned, these are small people, right? 0.7 years old to 17 years old. Now, I want to draw your conclusion to this, that in his data, right, 100% femoral nerve block success, lateral cutaneous nerve 92%, obturator nerve 88%, and then the genital femoral nerve 92%. And that's what made it very sexy. That's what everyone is dreaming about, that if we do this, we can get these kinds of results. But the real world situation is that doesn't happen. Capdevila also went on to describe it 10 years later, and he also showed two kinds of spread. In fact, he was trying to define three kinds of spread. Okay, one, the so-called medial spread along the psoas, right? And then one, the lateral spread across the iliacus, and then one, a proximal spread up to the roots. Okay. And what did his data show? That actually, there was zone B stretch. Okay, the zone B is actually where the iliacus is. The zone B spread was only about 30%. Zone A and B, okay, about 61%. And then zones A and C, all the way up, is about 2%. 2%, no. Okay, and where do you get 100% block of the three nerves? Zone C, A and C. So maybe if you do a fascia iliaca block, in 2% of patients, 2 out of 100, you will block all three nerves. But 98 of them, tak jalan. You might as well give a femoral nerve block by itself, and you might as well block this separately. So again, they use catheters. It's the same catheter group, right? What they did for these patients is that they actually put the fascia iliaca catheter in first. Okay, they got into the space, they thread the catheter, and then they inject the volume. And then he found that, okay, majority of the catheters were in the lateral space, right? Some in the medial space, some in the middle, and then again the same. Only 5% of catheters reach the plexus. Okay, so the success rates, of course, is the same, right? If you are in the near the plexus, your success rates are high, right? But even then, there's a 50% obturator nerve block failure. Now, I think the most controversial literature in the last year or so that came out is from Shariat, Ali Shariat in New York, right? Nisora group. And they did this fascia iliaca block with ultrasound, right? And then they found some startling results. Okay, they did it with ultrasound in a so-called infra-inguinal approach, in plane, trying to get the needle under the fascia iliaca and depositing the local anesthetic. And they call this a fascia iliaca block because, you know, that's what it is, right? Depositing local under fascia iliaca, right? And wow, look at the results, man. Femoral nerve block in only 38% of patients, no. More than 60% failure rate. No. Okay. Sorry, press the wrong button. Right, lateral cutaneous, 70% failure rate, no. Obturator, 75% failure rate, no. How to do? Might as well don't do. See, sham block 0, 100% failure. Not that far off. So, MRI studies were carried out by Svensson, and he described them again using just putting the needle under the fascia iliaca and injecting the volumes. And he used MRI to study the distribution. And what he noticed is that yes, there is some spread to medially, but they actually don't. He described it as spreading up to the vein, okay, the femoral vein, right, or up the iliacus to the notch, the ilio and psoas muscle notch, right, and all the way up to the iliac crest. Okay, and you look at the results again. Okay, for the fascia iliaca group, we don't look at the 3-in-1 group. That's not the study of the day. The study of the day is the fascia iliaca group. We look at the fascia iliaca group. The lateral cutaneous extension is only in 3 out of 5 patients. 60% never reach the lateral edge. Okay. Sorry, 40% never reach the lateral edge. That means these two, the spread didn't reach the lateral edge. Okay, and then if you look at the motor function, right? Yes, they all got some form of femoral nerve block. Okay, there's no doubt about it. But none of them got any adduction, muscle power reduction. Okay, so what does that imply? Now, nobody really knows how to test, or rather, there's no standardized way of testing obturator nerve block success. But this is probably the closest. That if the adductor muscle is not weakened, that means you kind of failed. Okay, so I hope I've shown you that this thing, to block 3 nerves with one single injection in one space, doesn't really happen. And so what is the best option? Is there a best option for the hip operation? Okay. Now, you heard of meta-analysis, right? Sometimes there's a lot of knowledge out there, there's a lot of data out there, so people are trying to churn it, okay? And this one is being churned in my favor, that's why it's being presented. Okay? Now, it's called a multiple treatment comparison, and essentially what they're doing is that they look at, okay, there are studies for A versus B, there are studies for A versus C, but there are no studies for B versus C. So never mind, we'll take A as a reference point, and then we will do some statistics and see what we can get out of this to prove that we can compare all three. Or, right, yes, there's A versus B, A versus C, B versus C, but we don't know what is A versus B, so we will just compare, A versus C and B versus C with indirect evidence. Okay, so this is even weaker than most things are. But guess what? It's working in my favor. So here you go. Okay, so they pulled studies, RRCTs from 1990 to 210. Okay, 2010. That's what? Again, stage anxiety. My maths is so poor. But there you go. Okay. And you look at all the blocks that were studied for hip fracture surgery. Okay, Fascia Iliaca block. This is like the forest plot in meta-analysis. Okay, if it crosses the vertical line, it's no good, right? More on the left side is good, right? So essentially, we're looking at the Fascia Iliaca nerve block. Yes, it crosses onto the left side, but the spread is very big. That means it's very variable. Okay, so if you just look at all the suggested blocks on the left column here, what do you see? You see that actually the literature suggests that you should just combine your nerve blocks rather than do one single magic bullet block. Okay, so I think with ultrasound technology, it's actually quite straightforward. Laterocutaneous nerve is easy to block. The femoral nerve is easy to block. So you can literally just redirect your needle to block both sides. Okay, the obturator nerve is also not difficult to block. You need a different entry point. And with ultrasound, it's really not difficult. Okay, again, using the same data, right? So they plotted it another way, and on the top of the list is actually the obturator and the laterocutaneous, lateral femoral nerve block. Okay, so I think what this suggests is that actually you should just be blocking the nerve separately if you don't want to do a psoas compartment block. And ironically, right, the psoas compartment block is quite close to the midline. I guess because the failure rates may be higher. Now, there is also this question of technique, right? We talked earlier in the morning during a live demonstration. There's an infrainguinal approach, there's a suprainguinal approach, there's a longitudinal approach, there's a transverse approach. So not all Fascia Iliaca blocks are the same, right? So it's really a question of technique and looking for spread. Now with ultrasound, it's easy to get under the Fascia Iliaca. There's no doubt about it. You're in the right space. But can ultrasound help us delineate the spread over the iliacus muscle intra-abdominally, retroperitoneally, medially and laterally? I think we're not really there yet. Maybe one day we will be able to ascertain a lateral spread, redirect the needle to get lateral spread, then medial spread, redirect and get medial spread, or ascertain the proximal spread up to the root level. But at this point in time, we can only see spread over the curve. Nobody has actually described lateral or medial spread on ultrasound yet. Okay. Now the other kid on the block, you heard about the QR block this morning, right? Guess what? These people have done the QR block for total hip replacement also, for hip surgery, not total hip replacement. There are two cases in the literature, neck of femur fracture and also a total hip arthroplasty for revision hip. Okay, they were performed using single shot QR1, quadratus lumborum type 1 block. Okay, 20 mils, and this one 30 mils, right? They add DEX because I think that's the flavor of the month in the institution, and DEXA. Case 1, actually the patient was supposedly able to walk within a few hours after surgery. Okay, again, this is all balanced anesthesia, right? Because they didn't block the sciatic nerve, they still have to give some form of narcotic. And case 2 had reported dermatome reduced sensation from T6 to L3. Okay, T3 to L6, T6 to L3. I think if you remember what I described to you regarding the superior cluneal nerves, right? The QR block probably has some contribution to blocking that aspect of the nerve supply to the area in the hip surgery, and there possibly is some spread towards the lumbar plexus as well. Now, so looking at all this QL1, QL2, QL3, right? I think everyone's getting confused. There's literature out there to try to standardize the nomenclature into the anterior or posterior and middle QL fascias, thoracolumbar fascias. So I think with that, like the QL is by no means clear that different approaches will produce identical patterns of spread. So like for the QL blocks, the fascia blocks are the same. By no means will you identify same spread just with that one needle location. In addition, not all blocks are the same. Not all QL blocks are the same. Not all fascia iliaca blocks are the same. So I hope I convinced you that you should stop doing fascia iliaca blocks for hip surgery. If you want to do anything, you should do multiple blocks because it's not difficult. Thank you.
Thank you very much, Dr. Chee. I think because of the time that he spent, then probably most of us will be convinced with his point rather than Mafis. Okay, I think in the interest of time, yeah. But Mafis blame me because I haven't enforced the format. But I think in the interest of time, we will move on to the next symposium. But I would like to invite the speakers, Dr. Mafis and Dr. Victor Chee, to please accept your token of appreciation. And Dr. Mafis?